Prevention of medical errors is the continuation of errors in medical practice. The same chapter, page number 91 onwards. Those who have the textbook, page number 91 onwards. How to prevent medical errors. So we'll start the session. So most errors can be prevented. Most of the errors that it takes place in medical practice, it can be prevented. Okay, basically just apply the principles of safety. Okay, and when we talk about patient safety, it's not just the absence of errors. Okay, safety has multiple dimensions. Okay, for example, we have to see that healthcare itself is a complex and a very risky business. Okay, and the solutions of a solution that took place in solution that worked for case A may not actually work for every cases. Okay, you don't have a tailor-made approach in healthcare. So that's the complexity of healthcare. You have to understand that. Okay, it has different processes. Healthcare has a different processes that identify what's a mistake, evaluate how it happened. Okay, minimize the hazards wherever possible, and you do not have a utopian healthcare system that works continuously. Okay, you have to always look for continuous improvement in every process of healthcare. That is one part. That the outcome, that outcome of a healthcare is highly unpredictable. Okay, it's not like a factory. Okay, where you get a simple same outcome every time. Okay, it's not like a factory. Okay, outcome is how, because of any internal or external factors, the treatment you gave to two different patients who were suffering from the same condition. Okay, how one person recovers and how one person doesn't. Okay, how a treatment which worked for others failed for another patient. Okay, so we do not have the control of outcome when it comes to healthcare. Okay, so that's the multiple dimensions of safety. Safety is not just that, it's a error-free medical practice. The dependence of technology has increased a lot over a period of time. Okay, if at all because of a glitch in the software or a glitch in the technology. Okay, and if the doctor or the healthcare practitioner is completely dependent on the technology, unaware of their natural human instincts. Okay, not working on their human instincts to approach a project, approach a patient, completely dependent on a technology. Okay, it can lead to unseeing. Okay, it can lead to unseeing various symptoms and management which could have been prevented. Okay, handheld is bedside computer, for example tablet. Okay, that is the best approach. Okay, instead of going and sitting in the nurse's station or a doctor's room on a computer and monitoring all the patients through that, it's better to go around, give your patients a personal one-to-one visit with a tablet in your hand. Okay, handheld tablet or a handheld gadget. Okay, which can move along with you, which is not that heavy. Okay, a small notepad or a laptop. Okay, which is lightweight. You can type the symptoms, you can type the treatment what you have given immediately. Okay, so that the software is also updated and you can see personally. You can also maintain that human to human contact with your patients. Lookalike sound like medications are also one of the major causes of healthcare medical errors. So make sure lookalike sound like medicines are not kept together. Okay, they are kept far apart. The nurses are aware of the names of lookalike sound like medications. Nurses are also aware of the high alert medications, what comes under high alert medications, what are the examples of high alert medications. Okay, then standardization of treatment policies, protocols, etc., to avoid confusion and reliance on memory. Okay, so if you have a standard procedures and policies for every approach, every processes in your healthcare system, you don't have to memorize the process and policy all over again. Okay, you just have to do your work. You just have to keep your um, human instincts alert. Okay, and just focus on the standard of operations, SOPs, to make sure that you are doing the evidence based practice. That's it. Next, coming to preventing errors in ambulatory care. Ambulatory care means when a patient comes for OPD visit. Okay, OPD visits are also called as ambulatory care or emergency department. That also comes under ambulatory care. Okay, so first is the multiplicity of the providers, because when patients do come for the ambulatory care, it's not just one doctor they are visiting. They may go to a general physician. General physician, based on the symptoms, they may refer the patient to some other specialist. The specialist may refer the patient to a radiologist for diagnosis, further diagnosis. Okay, two or three specialists may be involved. One general physician may be involved in this ambulatory care. Okay, diagnostics are involved, laboratory is involved. Okay, so there is a lot of providers. Okay, there are a lot of sub examination rooms, consultation rooms, sub OPDs. Okay, diagnostics, a lot of providers are involved in caring for a single patient. So there is a multiplicity of the provider. If there is something wrong in the communication, something was not communicated properly, the patient may have to bear the consequences. Okay, that is one issue. Then the patient visits are more as compared to the inpatient admissions that take place on an average day. Definitely, we all know that OPD visits and emergency visits have a much higher number and frequency. Okay, and the number of healthcare providers we have, specifically in a developing country like India, okay, the ratio between doctor and the population, what they're catering, it's already, there is a high gap, there is a huge gap, there is a imbalance. We have very less amount of healthcare providers, we have a lot of patient population. Okay, so they are already overworked and overburdened, so there are high chances of errors taking place in ambulatory care. Then intermittent communication between the patients and providers, there is not a continuous communication as compared to inpatient admission. Inpatient admission on a daily basis, as long as you are discharged. Okay, on a daily basis, you are meeting your specialist, you are meeting your doctor. Specialist and the doctor is coming and giving you visitations, checking your condition, checking your current state. That doesn't happen in OPD visits. Okay, in OPD visits, you just visit the hospital for a few hours, you're given prescription, you're given your care plan, you take that home, and you have to follow up later after a week or so. Okay, so for entire 1 week, there is no communication between the patient and the doctor. Okay, whatever doubts the patient may have, they may assume something and they may do something on their own. And if the medication doesn't work, if there is something overdose or underdose issues, the patient may have to bear the consequences. So that is called the intermittent communication between the patients and providers. The dependency of patients or providers error reporting, same. Okay, when something goes wrong at home, okay, what the patient may think, I will not go back to the doctor who gave me this prescription, I will go and see some other facility because this facility is not good. The medications this doctor have given me is not working for me, my condition is not changing, let me go to some other hospital. Okay, so the dependency or giving a chance for a doctor's treatment approach to work, okay, that is also quite low in ambulatory care. Then reliance on care plan, completely the patient is relying on what the doctor has said or what the doctor has given as medication. Okay, if they have an allergic reaction, if they have some side effect, okay, sometimes it is brushed under the rug. It is they may not come up with, they may not immediately go to the emergency to show the symptoms. Okay, they may try to go to some other facility. Okay, so they are completely reliant on the doctor's treatment care plan. So system redesign in ambulatory medicine, these things can help. Okay, this can help to prevent the errors that take place in OPD care or any ambulatory care. Okay, so first is the practitioner memory. So the medical system, even today, it relies heavily on the medical practitioner's memory. On any given day, the primary care physicians, general physicians, they have to remember all the diagnostic criteria, treatment options, specifics of dosing technique. Okay, make sure that the patient remembers to follow up. When the patient follow-ups, they have to remember what was the complaints exactly they have stated in the previous visit. Okay, so if the entire workload is memory-based workload, okay, so if you try to put some checklist, some reminders, some protocols, okay, computer aids, etc., in the general physicians with PC, okay, computer, a lot of load can be taken away from the physician to memorize the stuff. Okay, so that is something that we can do: checklist, reminders, some SOPs in the computer. Okay, second is information access. Improved access to patient specific information, for example, patient's charts, test result, knowledge database, etc., in the form of an electronic medical record. Okay, what kind of drug was prescribed in the previous visit, okay, and all the history of drugs taken by the patients in previous visits. Okay, these all kind of software can allow the physicians to make sure they have all the information that they need to make sure that which criteria of medication works for this patient, which doesn't. Okay, and without wasting time in trial and error kind of approach, okay, you can come straight to the point of giving what kind of treatment the patient may require. Okay, so that is information access. Second is error proofing the systems. It is very important because when you are working on a software based technology, hacking issues, okay, software internal errors, okay, internal discrepancies in a software, these all things should be error proofed. Otherwise, the patient may have to bear the brunt of this technological demise. Okay, standardize the process of care in such a way that SOPs are there. Okay, protocols, processes. And if you're working in an accredited hospital, it is well and good because you already have a standard process of approach to everything. Okay, when you get an accreditation, it automatically makes sure that each and every process under your medical care, under your medical center, is a standard one. Okay, this is what everyone else, every other general physician, every other specialist uses. Okay, so if your process of care is the standard one, evidence based one, you don't have to worry much about errors. Error avoidance as a part of medical training. When you are dealing with the MBBS student, okay, or you're dealing with a postgraduate student, they should know from their studying part onwards. Okay, it should not that they are pushed into the workforce and then they come to know what kind of errors may take place from the college state itself, from the student life itself. They should be made aware of the different scenarios of errors that can take place, previous cases that had took place based on errors of or error in medical judgment. Okay, these kind of case studies should be exposed to the students to read and know, okay, these things have happened, this can happen again, and how they can prevent it. Then we have electronic prescribing. What is the benefit of having an electronic prescription? That is software based prescription. Okay, that is, you should have a pharmacy software along with your hospital information system, and how it can help the doctors. It eliminates handwriting errors because nowadays, if you have seen any hospital that has a software for electronic prescription, it's so easy for the patients to read what drugs they require. There is no spelling mistake, there is no handwriting issues. You take that printed chart from your discharge summary, give it to any medical store. They can even understand that what kind of exact medication you require. Okay, so handwriting errors, transcription errors are avoided. It assists in dosing because the software itself will blink, or it may show a caution sign that you are dosing too much or you are giving too less of a dose. Okay, quick access to drug information. Sometimes a drug may be newly launched, or there is such a slight change in the brand name that is available. If the doctor want to read about it, they can click on that drug. They can see what our composition is there about this drug, what side effects it may cause, what are the contraindications, indications of a drug. It is all already present in the software. It is integrated with laboratory test. Okay, based on the patient's lab reports, what kind of drugs has to be are to be given, it will not automatically give you the list, but an awareness of the patient's laboratory test is attached to the prescription. Okay, prevent so that when you do medical audit, it is easier to understand how and why this drug was specifically prescribed. If you already have the laboratory test attached to the prescription, it is easier to explain to the medical audit team that why you have prescribed so and so drug for this patient. Okay. Prevent adverse drug interactions, because when a transcript is made of different drugs, okay, automatically some caution sign will be shown that the drug which you have prescribed just now may interfere negatively with other drugs that you have prescribed. Okay, so automatically that even if the doctor doesn't remember, doesn't memorized it, or doctor may have, we all are human, okay, we may forget about some adverse drug interactions, but the system gave you a cautionary sign. So because of which you were made aware of. Okay, 88% of reduction in medical errors was seen in all the hospitals which had used electronic prescribing. Okay, so this is the benefit of using electronic prescribing. So in hospitals where electronic prescription is unavailable, that is a scenario of most of the Indian hospitals, public healthcare systems. Okay, avoid verbal orders until and unless it is an emergency. Don't give verbal orders to the pharmacy or to the nurses to get a drug. Okay, and if you have to use verbal orders, make sure you immediately fax it. Okay, as soon as possible, a fax has to be sent to the pharmacy that this drug has to be sent immediately. And when you are on telephone and you are calling in for a drug, spell the name of the drug in verbal orders. Okay, spelling, and make sure you say each numerical dose. For example, you will not say uh, diclofenac 15 mg. No, diclofenac. You will spell the diclofenac spelling. And instead of saying 15 mg, you will say 15 mg. Okay, so don't say numbers like 23, 50, 100, something like that. You have to say 50 for 50, 100 mg for 100. Okay, like that you have to say each numeral in the dosage. Okay, and at the end of it, when the verbal order is given, you have to ask the pharmacist to repeat your order. Okay, the pharmacist has to say back whatever you have ordered just now, so that the two-way communication is clear. Okay, so these rules you have to follow when electronic prescription is not available. Avoid polypharmacy. Polypharmacy means a single case of patient is having a lot of medication, or is put under a lot of medication. So try to minimize the number of medications a patient takes, okay, on a daily basis. That is the main motto of avoiding polypharmacy. Complete and accurate patient medication list is critical, especially in the discharge summary, what you have given to the patient when during the course of treatment, and at discharge what they have, what are medications they are going to take. Nothing should be left out. Okay, a complete list of that medication is critical here. Patient should carry the list whenever they come for OPD visit. Okay, and the list of medication they are continuing or they are taking right now. They have to bring that list. And if at all they have lost the list, no worries. They can bring the blisters or the medications or the bottles, syrup bottles, whatever they're taking. Okay, they can bring the medication to the hospital for their follow-up visits. Okay, sometimes it's a human nature that you may lose your medical record, or you may lose your prescription papers, etc. Okay, but if you know that you do not have the prescription paper with you, at least bring all the medications that you're taking, even if it is Ayurvedic, homeopathic, or allopathic medication, whatever you're taking, bring it to the hospital visit and show it to your doctor that these are the medications that I'm going on. So based on which the doctor can make a calculated treatment, so that whatever medication the doctor prescribes you next does not interfere negatively or does not give a wrong interaction with your present prescription. Okay, so that is the motto of avoiding polypharmacy. It's an effective drug monitoring system. So this is again a hospital information system, sort of. This is where every patient record uh, is integrated with the pharmacy record in such a way that when you can see here, a patient got admitted, sample collection was done for laboratory test, okay, and in the laboratory sample analysis was done. You got the result, okay. This result will be kept, okay. The result will be kept in the laboratory information system, okay. It will not be discarded. Sample analysis was done from the laboratory and the reports came back. The doctor will now do interpretation of the report to find out what diagnosis should be given, okay. Medical judgment means a medical diagnosis is made, and based on the medical judgment you have to do the adjustment of the drug dosage. For example, let's say it's an infection, okay. It's a multiple bacteria that are causing infection. High-end antibiotics was given to the patient, okay. Over a week sample collection was done. Symptoms have reduced, but infection is not completely gone, okay. Earlier there were 4 to 5 different kind of bacteria infecting the patient, but now only 2 different bacteria are infecting the patient. So definitely you can change the antibiotics, okay. What high-end antibiotics you are giving for the 5 days, you can stop it and you can go to a lower end of antibiotics, okay. So that's the drug monitoring system. It is completely based on the patient's samples, okay, laboratory samples and present medical judgment. You have to continuously evolve your prescription. You have to continuously adjust your drug or dosage prescription. So this is a drug monitoring system. Drug monitoring system works hand in hand with the laboratory results, okay. In present tense, continuously it works hand in hand with laboratory test, so that continuously the drug and the dosages are adjust based on the patient's current scenario, okay. Then efficient follow-up on tests and referral. Test tracking system is also that. Test tracking system is done in the laboratory. If the patient has a high creatine level or something and the patient is still admitted, okay, from the laboratory, intimidation may come. Have you redone the creatine test after 3 days, okay, or after 4 days? Have you done the creatine test? So even if the physician may have forgotten to do the written test, but the intimidation from the laboratory information system is present. Okay, so that's an example of test tracking system. Okay, so so even if the general physician or the physician forgets about certain tests that has to be done, intimidation comes from the software itself. That a reminder or an alert comes from the system itself, that for this patient on bed number so and so requires this kind of test, should be initiated or not, and the doctor may have to click it. So immediately the information will go to the nurses to collect the sample, send it to the laboratory for the test to be done, okay. Inclusion of pharmacist on hospital round. It's not possible everywhere, but even if not the head pharmacist, at least the assistant pharmacist can come along with the hospital rounds. So they will also get the details, so that they do not misinterpret the drug prescription. They get to know exactly why this drug is given for this particular patient. Okay. So there is no default or there is no fault in getting the wrong medication from the pharmacy. No fault compensation for errors has been proposed. That is, this is where like for medication errors, when for in medication errors, when something wrong has taken place, okay, there will be no compensation given from the hospital. The doctor may have to bear the compensation. That's one policy. So if this kind of policy is put into place, doctors will get more and more vigilant about medication errors, okay? Because the hospital has gave up their hands. They will say, we are not going to compensate the patient for medication error. The doctor themselves has to make way around it. So when this kind of policies is put into place, it makes the doctors more accountable of the medication errors. Okay. Then apology whenever and wherever apology is required, uh, and in a formal way, if medication errors has caused some negligence, has led to medical malpractice, had led to some grievous harm that has done to the patient. Okay, formal apology, okay, has to be initiated from the culprit's side, okay, towards the victim. To improve is human, that is always make sure you have room for improvement. Okay, if a system works for you, doesn't mean that it cannot be broken. It can break at some point of the time. So always be vigilant and keep an eye out where we can improve more. Which area of this working system requires more nitty gritty to be added to it. Okay. Then coming to the errors that should not happen. National Quality Forum from US. Okay, it's a US based forum. They have enlisted 28 errors. Okay, and these all errors should not at all take place in a healthcare system because it comes under gross negligence. Okay, so it's on page number 96 to 97. I'll go through the 28 errors that should not taken should never happen at a hospital. So the first one is surgery on wrong body part. Those who have the textbook, they can follow together. So the first error is surgery on the wrong body part. Surgery on wrong patient. Wrong surgical procedure performed on a patient. Object or any article left in the patient after surgery. Death of a patient who had generally been healthy during or immediately after the surgery for a localized problem, for a simple problem. It could be a best example is pulmonary embolism or some kind of embolism or thrombus, okay, leading to the death of the patient who was completely normal. Okay. Next is patient death or serious disability associated with the use of contaminated drugs, devices, or biologics, unsterile prosthetics, or any device put inside the patient during surgery or during any treatment. Okay. And that caused death or serious disability. Patient death or serious disability associated with misuse or malfunction of a device. Okay, device kept inside the patient's body or patient was attached to a certain device and it became malfunctioning, leading to some negligence. Then patient death or serious disability associated with intravascular air embolism, okay, or thrombus also. Infant discharged to a wrong person, okay, after birth, wrong baby was sent to with the wrong parents, okay. Patient death or serious disability associated with patient disappearing for more than 4 hours, okay, like patient getting stuck in a lift, okay, or patient was sent into a wrong ward or wrong diagnostics, and for hours the patient was missing because maybe the patient was unconscious, comatose, and there was a delay in treatment and the patient passed away. Okay, these kind of errors. Patient suicide or patient attempting suicide resulting in serious disability. Patient's death or serious disability associated with medication error. Death and serious disability associated with transfusion of blood or blood product of wrong type. Okay, patient required A positive, you transfused B positive. Okay, that's an example. Maternal death or serious disability associated with labor or delivery in a low risk pregnancy. A pregnancy was a low risk one, but still it led to maternal death or disability. Patient death or serious disability associated with hypoglycemia. Death or serious disability associated with failure to identify and treat hyperbilirubinemia in newborns. Children who are born with that yellow uh, uh, skin color, okay, because of a newborn jaundice, etc. Okay, phototherapy is prescribed usually, and if you are not able to identify this situation, it can lead to infant mortality. Severe pressure ulcers acquired in the hospital, that is the bed sores. Patient death or serious disability due to spinal manipulative therapy. Any spinal cord injury that took place during a therapy or treatment, maybe during general anesthesia as well, that there is a risk of it. Patient death or serious disability associated with an electric shock. Any accident in which a line designated for oxygen or other gas was delivered to a patient contains the wrong gas and contaminated by toxic substances. Okay, like in certain hospitals, instead of line, they use gas cylinders to give certain gases to the patient. Okay, it's usually oxygen gas, etc. But instead of giving the inhalation of oxygen, you gave patient the inhalation of some other toxic gases. Okay, that could lead to patient death. Death or serious disability associated with burns in the hospital. The patient acquired burn within the hospital. Patient death associated with fall suffered in a hospital. A minor fall may lead to, in old age patients or patients who suffer from osteoporosis, a small hip fracture can lead to fatal conditions. Death or serious disability associated with the use of restraints or bed rails. Any instance of care ordered by or provided by someone impersonating a physician, nurse, pharmacist, or other licensed healthcare provider. Okay, some person who is not a practitioner, but they wore a practitioner's uniform, used mask to cover up their face, and gave some treatment. Okay, usually, most of the poisoning cases, some of the terrorist activities, all work in these kind of situation. Okay, so that is also a serious error that should not take place. Abduction of the patient, that is kidnapping patient. Sexual assault on a patient. Death or significant injury of the patient or staff member resulting from physical assault in a hospital. Okay, physical assault led to patient's death or even staff member's death. Artificial insemination with wrong donor sperm or donor egg. Okay, that comes under the gynecological practices. So these are the 28 errors that should not ever happen. These errors are given by the National Quality Forum of US. So NQF stands for National Quality Forum. So they have endorsed a set of safe practices. So on page number 97 to 98, you can see 28 practices, safe practices. Okay, a culture of safety. Okay, a criteria of inclusion for all patients, irrespective of their religious belief, ethnicity, caste, race, etc. Specificity of being specific with what treatment, what diagnosis, what treatment have to be given. Every drug what you prescribe should be specific for its purpose, benefit to the patient as well as the benefit to the people who are practicing the medicine. Evidence of effectiveness, always practice evidence-based medical, or always go for evidence-based medical practice. Generalization means the procedures what you use should be standard. Okay, SOPs are the ones that you should put into place for every patient to go by the SOP procedure. Okay, readiness to change. Okay, readiness to continuously improve and readiness to change. So these are the mottos. Okay, normal mottos what we follow in the NQF safety protocols. So in detail, it is given on page numbers 97 to 98. There are 28 set of rules of safety, inclusion, benefit, evidence-based medical practice, SOPs, continuous improvement-based medical practice is given. You can read it. It's more on the clinical side, so only a medical practitioner can read and understand these areas. It's not administrative. Okay. So what patients can do as a part of a patients are also a part of a healthcare team right now. They are the central part of a healthcare team. So what they can do to prevent errors in medical practice. So patients have to be involved in the healthcare. They should have a voice, they should have an opinion in their own treatment and care plan. Okay, the medicines that the patient gets, okay, they should know, they should make sure that the count of the medicine is same every day. If a medicine is missing, they can ask the nurse that this is missing. If there is something new added, they can ask the nurse or the doctor, why is it that this added, what is the benefit of it. They have the right to question the doctor or the nurse about the medications given to them. Okay, and whenever the doctor is making a prescription, okay, or no, or anyone is writing down a note in your discharge summary, if you are not able to read it, if you're not able to read it, you have to clarify it with the uh, prescribing physician, that please write it in a proper handwriting so that I can read, okay, if it is not typed out. Always be aware, okay, make sure that when you are getting your prescription from the pharmacy, check that your name is mentioned on the prescription list or not. Maybe at the same time various many patients may be going and collecting the drug from the pharmacy. Don't mix up the drugs, okay, check it in the pharmacy itself. You can read the brand name, the drug name prescribed, and what you have got. Everyone can read that and understand, okay, it's the same thing. If you have any doubt, ask the pharmacist itself. So that's what you can do with medications. When it comes to hospital stay, patients have a choice to choose a hospital, how many days they can stay, if they want to be referred to some other hospital, etc. So hospital stay, if it is prolonged and they want to go home, you can take LAMA, leave against medical advice, or discharge against medical advice, and you can seek other facilities as well, whichever is cost effective. No hospital can force you to stay. Okay. Surgery, if you're having the surgery, make sure you know exactly in which area of the body surgery will be done. Okay, you know the exact procedures, what are going to take place during the surgery, because in informed consent these things are explained. Okay, ask the doubts that you have, whatever questions or whatever situations you may have to face with after the surgery. Everything has to be cleared beforehand itself. There are other steps as well the patients can take. Speak up for yourself. Whatever questions and concerns you may have, speak it up. Make sure the healthcare professionals are as involved in your healthcare plan as you are, as invested in your safety as you are. Okay. And make sure that a family member or a caretaker is there with you at all times to be your advocate. If something goes wrong, if you have to sue the doctor or the patient tomorrow, okay, they should have somebody as a witness. Okay, patient should have somebody as a witness from their side as well. How much ever questions or queries you may have, it's the duty of the doctor or the healthcare practitioner to answer all of those concerns, answer all of those questions. Nobody can tell you that you are asking too many questions, I'm not going to answer this. Okay, so these all are the things that the patients can do for their well-being.